I want to welcome everybody to today's topic, pathophysiology and coding of bleeding conditions and disorders. And I'm so excited to welcome, first of all, Ed O'Byrne to the Haugen Consulting Group, but also to kick us off for the 2020 webinars today. So Ed, we're so excited to have you here. For those of you unfamiliar with Ed, he's been in healthcare for 30 years. He first started as an emergency room PA. Then he decided he really wanted to get into that coding stuff. So he became a production coder, manager, consultant, and now he loves the education role. He's a well-known speaker for AHEMA. He presents education on CM, PCS, CPT, and the beauty of it is he offers that from that clinical perspective. So I'm really excited to hear today's presentation. He's well known for explaining complicated subjects in an easy to understand way. So you'll have to let us know what you think about him today. I do want to mention on a personal note he shared with us, he loves to skydive. In fact, he has over 1,000 skydives and 600 hours of private pilot flying time on the books. Now he tells us that he gets his thrills educating coders and providers and lives for those light bulb moments. So Ed, I think at this time, I'm going to turn it over to you.
All right, thanks, Kathy. Whoa, look at that. I'm in the presentation. How do you like that? Well, I'd much rather be with you in person, seeing your hopefully smiling face, but I think this is the least I can do so that you can see me. And this is one of those things in the survey. Would love to hear back from you if you find this useful or distracting, or if you'd rather I be, in the bar above, which is sizable or hideable if you don't want to see, or if you just don't want to see a presenter at all. Won't hurt my feelings at all. Well, the occasion for today's presentation is that January is National Blood Donation Month, and if you are somebody who does so, I would encourage you to go out and do so. Otherwise, this is a topic that crosses many different subjects and chapters in ICD-10, so this will be kind of an adventure, exploring around the pathophysiology and physiology really of blood and its clotting capabilities and the coding of those. So it won't be open up a chapter and just linearly go through that too, so buckle up for a few twists and turns. So there's been a long-standing poetic explanation about the composition of our blood having some connection with the world's oceans, maybe, whether you're evolutionist or creationist. And although they do contain a lot of the same stuff, it's in very different ratios, as you can see, of sodium, chloride, calcium, magnesium. Now, for aquatic organisms that don't have circulatory systems like we do, this is very useful. Seawater also carries oxygen for those, whereas our blood does that for us. And that's one of the biggest takeaways from today's presentation is the oxygen carrying capacity of our blood and what goes wrong. But one of the biggest things that doesn't show up here is the ratio of iron in blood, 500 to 1 to seawater too. So that's clearly a big distinction. Also, fun facts for your post-holiday parties, should you have any, the specific gravity of blood is 1.60. The viscosity of blood is 4 times that of water. Therefore, scientifically proven, blood is thicker than water. So there you have it, heard it here first. So the main cellular components of blood are the erythrocytes, or red blood cells. You see, have a nice little scanning electron microscope picture, falsely colored for our pleasure, but you can roughly see the size ratio, and that varies because there's different kinds of white blood cells, of course. All of these cells, the leukocytes, thrombocytes, and erythrocytes, are carried by the plasma, and that plasma carries all the electrolytes, the proteins, the antibodies, the fat micelles, hormones, all that stuff in the blood that our tissues need, as well as the oxygen that the red blood cells carry. Now, for our talk today on hemorrhage and bleeding conditions, we'll focus on the conditions where there's not enough oxygen carrying capacity, not enough pressure to get that blood around, or the blood ending up in some places it doesn't belong and causing a problem there. Now, here's some of the sort of an expanded view of the functions of the blood. I have to marvel on this. Of course, I was in medicine and I'm in coding, and I've never a dull moment. I never tire of reading about the physiology and the miracle of life in medicine and biology. But just take a gander at these. The blood, not as a formal organ, but I think of it as an organ because it's so complex in what it does. It supplies oxygen to our tissues, nutrients like glucose we're familiar with, which participates in cellular respiration with that oxygen for energy. All the amino acids for building all of the proteins in our body got there through the blood. And then the fatty acids we use for energy, hopefully, or get deposited somewhere. And then removal of waste from the metabolism and the use of all those substances, some of them gaseous like carbon dioxide, some of them solid in solution like urea and lactic acid. And then there are the white blood cells and the non-cellular immunologic functions, the antibodies, those complex proteins that help fight infection, even though they don't kill it themselves usually. Coagulation, blood's got to have a way to stop itself from flowing out of the body, and that'll have a great emphasis during our talk today. Hormonal transport, as we know, we have endocrine organs throughout our bodies, the adrenals and the pituitaries, thyroid, ovaries. How do they get the hormones between them in the bloodstream, of course? And then the kind of lesser appreciated regulation of core body temperature through dilation and constriction of the blood, of the capillaries in the skin, keep us the right temperature. And then hydraulic functions like the congestion you get in your nose or erection. The blood pressure is what causes that tissue to distend. And some of the medicines to treat it, like pseudoephedrine, shrink those blood vessels, lower the pressure in your nasal congestion. That's how it works. That's all hydraulic pressure in the bloodstream. So as far as the circulatory system, a little background on that. So our hearts beat an astonishing 2.5 billion beats per lifetime. That's a massive number of anything, and it never ceases to amaze me to think about that. It never stops till we're dead. The typical healthy systolic blood pressure of the 120 millimeters of mercury, that's the familiar top number under blood pressure of 120/80, which I'm proud to say I have with the help of some medicine, is 1.6 meters worth of blood, the column of blood, and that's 5.4 inches. So that's enough to pump blood to any part of the human body in any position, upside down, sideways, and so forth too. I can't help but think that it was kind of designed that way to have that pressure right there to accomplish that task. Now, as for the blood vessels, with 100,000 miles altogether, there's plenty of opportunity for them to become injured or lose their seal and let blood go where it shouldn't go. And this, in fact, happens thousands of times per day. And that we have amazing mechanisms to help plug off those leaks, as it were. And some of the blood can go into the lumen of an organ or a potential space like the peritoneal cavity or the pleural cavity, or into solid tissue. So those are just some of the things we'll explore. What's the big deal with blood? Well, oxygen is where it's at. Blood is a pretty substantial portion of the body composition. It's about 5.5 liters. That's 7% of your body weight. That surprised me when I learned it. The oxygen carrying capacity that you see here, heme, is mostly comprised of carbon, hydrogen, oxygen, a little bit of oxygen, but one atom of iron. And that is further enveloped in globin protein molecules too, hence the hemoglobin. And that is 15% of the weight of blood, the hemoglobin, and it's all in red blood cells, minus a trivial amount from injured red blood cells. That is the stuff we need to carry blood rapidly to the body's tissue for cellular metabolism. Now, would you believe that the average human body has only 4 grams of actual iron in it? That's less than the weight of a nickel. Like an American nickel is 5 grams. That's astounding to me. So this carries 98% of the oxygen in the blood, with only 2% of the oxygen absorbed from our lungs, carried in solution, like a regular solution like water, an aquarium or ocean and so forth. Now, this is interesting that in blood gas measurements, the saturation is determined or is inferred from the partial pressure of oxygen dissolved in the blood, and then through a series of mathematical relationships, they can determine the amount of hemoglobin saturation, whereas in SaO2, the saturation is measured directly using transmitted red and infrared light through the skin. I was a respiratory therapist. That was my very first job in medicine too, and I drew a lot of ABGs, got well acquainted with this, and just the idea that hemoglobin is so hungry for oxygen that it sucks up 98% of it, that makes its way into the bloodstream, is amazing. This should be the last. I'm sorry I didn't warn you in advance for those of you who don't like blood. There's nothing really terribly graphic in here, but there's a little bit of blood. Sorry for that. So what can go wrong with these systems now that we've understood how important they are to us? Well, they're the root causes for the bleeding disorders that cause it, but it's worth pausing to note the outcomes and ill effects of bleeding on the body, and some of them are very acute and some of them are very slow. The main issue is anemia. With anemia, external hemorrhage, and GI bleeding is the loss of the oxygen carrying capacity. And the problem to do with bleeding into solid tissue or confined spaces is the body has to do with the undue pressures that exerts on that tissue that it's in or surrounding. The brain is especially susceptible to all four of these type problems, to oxygen starvation, the mass effect, having tissue in it, or having a low blood pressure to perfuse it. So we will get to intracranial hemorrhage in some detail later on too. So as I mentioned, all those substances in the blood can cause a lot of direct inflammation because the composition of blood is unique to the organs of the body. So there may be, for example, in almost all cases, an excess of iron, for example, that can be very irritating to the tissue, can cause things like pleurisy if it's into the lungs, or peritoneal signs, rebound tenderness. You may see that if there's blood in the abdomen because of that irritation. So I think now, having described the oxygen carrying capacity, I think almost a bigger miracle is the ability of the circulatory system to keep the blood in the pipes in the first place. And there's so much opportunity to lose blood through all those miles of blood vessels. So due to any number of obvious injuries or even microscopic tears in the capillaries and leaks, often thousands of times, maybe 10,000s of times a day in the GI tract, like if you ate something that was kind of coarse, that's going to scratch your esophagus, your stomach, and your small intestine all the way down, and it'll create tiny bunches of tiny little bleeding areas. But fortunately, we have a mechanism to seal up those little holes. Now, first in this system are the platelets, which we had a picture of a short time ago, and those are both a physical patch for the holes, and they can't do it by themselves. They require what's coming up next. But they also express some of the clotting factors too. So they're anuclear. They don't really do much except be there to clog it up, but they do express some chemicals that promote the coagulation cascade, which we see here on the right. It's a very complicated system. Then we have this so-called the coagulation cascade. You see on the right here. Don't be frightened by that. Okay. This is meant to keep the blood in a liquid state when it needs to be, but to form a relatively solid state. Clotted blood is more like jello than not like a rock, but it's a relatively solid state. And it's in a very fine balance too. Now there are chemical triggers that initiate this process, this complex multi-step process, and it all ends in fibrin. That's the substance which knits together the platelets to form the clot, which plugs up to all of the bleeding sites, large and small. Fibrin is the final step here, where thrombin turns fibrinogen to fibrin, and that forms that clot too. So now I've learned and forgotten this diagram plenty of times in school, so don't feel bad if it doesn't click. There are many instances of this online if you ever need to revisit it, but maybe not. I will mention just one thing. There are two main pathways, the intrinsic and the extrinsic, which work hand in hand to form the clots. The extrinsic, which is here on the right, kind of the right half of this, initiates the clotting, and the intrinsic more amplifies that, although there are certain instances where the intrinsic pathway can start the clotting. The significance of me mentioning that will turn up in just a moment too. Now you'll notice there's a lot of Roman numerals on there. That becomes significant to the coding and also the pathophysiology of certain bleeding disorders too. Most of these are proteins of various complexity. Calcium is one, and there are other non-Roman numeral names like protein C, protein S. You'll see the deficiencies in those will impair clotting as well, and there are particular codes for that. So now that I have sprung on you the coagulation cascade with the intrinsic and extrinsic pathways, I want to emphasize it doesn't matter which pathway a drug affects. As far as using the code D68.32, that's hemorrhagic disorder due to extrinsic circulating anticoagulants. Okay, the concept of the clotting cascade has to do with where the initiating or inciting event occurred on a cellular level. It won't go any deeper than that. The choice of extrinsic circulating anticoagulants has to do with the fact that the substance causing the coagulopathy comes from outside the body. So all anticoagulants are classified as extrinsic, no matter which pathway they affect. In fact, heparin affects the intrinsic and Coumadin affects the extrinsic pathways, but they're all classified to D68.32. In fact, you can look, here's heparin. Coumadin isn't mentioned, but you can take my word for that. But here are the intrinsic ones. Notice there's no drugs in here. These are all substances that may occur normally in the circulation, well, abnormally or abnormal levels of it in the circulation too. So hopefully if there was one or two of you confused about that, that may have fixed it, but I didn't want to let that go without making some clarification. Now, there are some of them, here are some of the more common disorders which affect the coagulation cascade implicitly, inherited conditions and acquired conditions both. None of these are actually really that common, but these are some of the ones that you may come across, and they are in ICD-10 in a way that it's important for you to make the distinction. Each of these affects typically the inherited one step in the coagulation cascade, and then in the case of vitamin K deficiency, kind of affects 4 in an indirect way, which I'll show you a little bit more. Now, factor 8 deficiency is hemophilia A, factor 8 deficiency, and that's classic hemophilia. That's the one that we've known for the ages. We thought that it was the type that caused the inbreeding or the death, and many times at childbirth, many of European royalty, because they had developed this propensity for factor 8 deficiency and inherited and inbred with each other, and so lots of them had it. Turns out there's a theory that a lot of that actually might have been Christmas disease, which is factor 9 deficiency, or hemophilia B, Christmas disease. So now, until the 80s, factor 8 was extracted from pooled plasma. And so it would take hundreds or thousands of batches of donated plasma or sold plasma, pull it together and extract the factor 8 until, unfortunately, as you can guess, the advent of HIV during the 80s caused a lot of hemophiliacs to contract HIV, unfortunately. Nowadays, we not only get it from probably the path it would have taken, as we would get it from known single donors and tested, of course, but actually it's recombinant now, so we get bacteria to grow factor 8 for us, and so there's never any possibility of viral infection there. Then we have vitamin K deficiency. It is an acquired condition, which is often dietary or due to some secondary, some other metabolic condition the patient has with absorption or processing the vitamin K, or a combination of both. And that affects the production of factors 2, 7, 9, and 10. So it kind of touches on each of those too. So now there's a certain way we can affect that pathway with vitamin K in a therapeutic way. Before we get there, to look at coding for these inheritable coagulation disorders, it's pretty straightforward, honestly. D66 for factor A, or for hemophilia A, factor 8, D67 for hemophilia B, the Christmas disease, D68.1, and this falls under the other coagulation defects. That's one of the named hemophilias, but it falls out. But it's not hard, so crack your ICD-10 and have a look at that if you like. Von Willebrand's disease is also in that same neighborhood too. That doesn't affect one of the Roman numeral factors, but one of the cofactors. But interesting to note, if you're looking for an extrinsic cause, like the vitamin K deficiency, notice that that's in the metabolic and nutritional, or endocrine and nutritional chapter, because that is not to do with the inherited availability or not of the factors, but rather some external factor that then affects the production of those factors. Now, Coumadin, speaking of affecting the vitamin K pathway, is the brand name for the chemical warfarin, which works by blocking a specific enzyme that recycles the vitamin K, which is in turn involved in the production of those 4 clotting factors. So this slows down the coagulation cascade at several points, and hopefully a very fine-tuned way. So what happens when someone has blood over-thinned by Coumadin therapy? Medically, the initial antidote is to give vitamin K intravenously, which will boost production of those particular factors, but only indirectly, in the sense that that replenishes the vitamin K, which overwhelms the Coumadin and then allows the factors to be produced. But this takes a little time, so whether we can treat it that way or not depends. If a patient is actively bleeding or their blood is far too thin, too anticoagulated, then plasma, like fresh frozen plasma, which is, by the way, it's frozen at the donor end, it's not given to the patient frozen, like a smoothie, but that replaces the deficient and, in fact, all the clotting factors immediately. So it's actually good for all of the Christmas disease and the von Willebrand's. Any of those actually works well. So now for coders, the conundrum comes with the Coumadin coagulopathy. That's something we see, I at least have seen documented a fair amount, and I documented it myself a fair amount when working in the emergency department without really understanding all the implications. Now, Coumadin, of course, deliberately and therapeutically slows down clotting in patients at risk for thrombosis, such as atrial fibrillation. And the amount of clotting inhibition is measured by prothrombin time and almost always expressed as an international normalized ratio, INR, with normal being between about 0.8 and 1.2. And therapeutic, depending on how likely the patient is to clot, whether they have propensity to pulmonary embolus or they have a mechanical heart valve or atrial fibrillation, it's usually between 2 and 3. But tuning that INR can be delicate. So what happens if you go too high and the clotting pathway is inhibited too much? Then the various sites of bleeding may occur, notoriously the GI tract. And in fact, that's exactly how warfarin rat poison works, is it causes the rats to just hemorrhage into their intestines. So how do we code for this? First, you'll need your actual bleeding code, whether it's GI bleeding is the common one or otherwise. And then we would have, an example would be like K92.2, GI bleed not otherwise specified, but there's lots of other possibilities. I didn't put them on the slide. Then, since we have a hemorrhagic disorder, we would use the D68.32 hemorrhagic disorder due to extrinsic circulating anticoagulants. It's a blood thinner that came from outside the body. And then finally, is this a poisoning or an adverse effect? How do we figure that out? Does it matter how bad the effect is? Is it, if a patient has easy bruising versus a massive GI bleed, does that make it a poisoning because it's really bad? No, it just comes down to the dosage and whether the patient took it as it was intended and prescribed. We just have to fall back on our poison coding guidelines, and it all has to do with whether it was taken as or administered as prescribed. Now, what if the dose just turns out to be more than was needed too? Well, once again, if it was prescribed and taken as planned, it's just an adverse effect, not a poisoning. So don't overthink it in that way. Maybe I'm alone in that respect, but I had a tendency to do that at first as a coder. Now, if it is a poisoning, of course, the poisoning code will be coded, or sequenced first, I should say. Usually the PDX, not always. The rule is that it could be coded before the manifestation, not necessarily the PDX, but in reality, it's usually the case. If it's an adverse effect, taken as prescribed, patient has bleeding, that would be sequenced after. And then finally, a patient who has just simply high INR but no bleeding, well, we can't use the hemorrhagic disorder here for D68.32, nor poisoning or adverse effect necessarily. All we have to work with there is R79.1, abnormally prolonged bleeding time. So polling question number 1, Kathy, if you'd like to.
Absolutely. So this is when we want to hear from you. So which of these is a real bleeding disorder? What do you think? Is it Thanksgiving disease? Is it Christmas disease? Or is it holiday disease? Boy, you guys are quick. I just glanced over because I always like to at least hear from 3/4 of the audience, because this is your time to let us know if you're having questions. Are you following along? So let us know. So which of these is a real bleeding disorder? And your choices are Thanksgiving disease, Christmas disease, or holiday disease. And I have to say, so far everybody is on one choice. So anybody else want to weigh in? I'd like to get a couple more of you just to see, like I tell some of our other presenters, when I get multiple choices that come up, I'm like, ooh, we're going to have some really good discussion. With this one, you guys are right on the mark. So I think you guys kind of have an idea already. So it looks like I'm going to go ahead and close the poll. 3, 2, 1. Okay, Ed, right across the board, 100%, they were very quick. They said it was Christmas disease.
Well done, my friend. I guess most of you are at least keeping a little bit of attention. I'm glad to hear that. The right answer was Christmas disease. That's hemophilia B, and that is not named for Christmas, the holiday, but the surname of the first patient was discovered in a particular Stephen Christmas of Canada in the 1950s. So that's factor 9 deficiency, and he relied on plasma transfusions to live, and he unfortunately also got HIV, just like a lot of hemophiliacs. But although nobody answered, I'm just gonna joke about these for a sec. Thanksgiving disease would be abdominal distension, I think, and holiday disease, I don't know of a holiday disease except like an empty bank account. and a bunch of toys around the house, like I have little kids. But of note, if anybody had answered that, they might have been thinking of holiday heart syndrome, which is a real thing. It's an occurrence of arrhythmias around holiday times, overindulgence of alcohol and stress, both of which are abundant at holiday time, and it causes arrhythmias, which can tip a person over into heart failure who maybe just kind of been borderline too. So not a code for it. We just code the arrhythmia or the failure and so forth. But now you know, holiday heart disease, or holiday heart syndrome, really. Okay, more blood thinners. Plasmin, before I get to the TPA, plasmin is an important enzyme present in the blood that degrades many blood plasma proteins, most importantly in our discussion, fibrin clots. That's remember the stuff that knits together the clot itself. Plasminogen, you see here in the diagram, there's not a big cascade here. It's just really a straightforward plasminogen to plasmin cuts fibrin. Simple as that. Plasminogen is integrated into all clots when they're formed, sort of a built-in expiration date, as it were. And then that plasminogen is activated slowly into plasmin, so it dissolves the clot from the outside in by cleaving the fibrin, so it breaks it apart, because you can't have these clots hanging around forever. So that's how that works. So cleverly, what about when we need to dissolve clots quickly, such as in thrombotic CVAs or MIs, pulmonary embolus, any case where there's some clot blocking blood where it needs to go. So we've developed tissue plasminogen activators, which stimulate plasminogen converting into plasmin to break down that fibrin clot. This generates several fibrin degradation products, as you can see here, which are soluble and they drift away from the clot. Interestingly, side note, one of these degradation products is D-dimer, which, as you may recognize, is an actual diagnostic test for certain conditions where there's a sort of a large volume of clots, like pulmonary embolus is the main one we use it for. It's not a very specific test, but it can help sort of point the clinician in the right direction. So that's a D-dimer. But back to the TPA, ideally, TPA, tissue plasminogen activator, is given through a catheter right at the clot itself at a low concentration, a high concentration, low dose for the whole body. But in a pinch, in the emergency department, it is okay to, or really anywhere where you can't have a selective catheterization, it can be given through an IV, and it will just amp up the plasminogen conversion throughout the body. Hopefully it dissolves the clot, which is the culprit, but it will dissolve clots anywhere, including all of those thousands of clots which form normally throughout the day. So these are some of the names you may recognize from the documentation. They'll end in Plase, which was a throwback to the plasminogen, as it were. Alteplase, I think, is more of the common one that I'm used to seeing, but you may encounter any of these and new ones every day, really. So let's talk about some other blood thinners and how they are classified in ICD-10. Heparin activates antithrombin, which inactivates thrombin, and therefore factor X, which I don't expect you to remember. I don't, but that is a different pathway from Coumadin. Yet it is still classified under the anticoagulant code family, whether it's an adverse effect, poisoning, underdosing, etc. You have two more digits there, of course. T45.51, so it doesn't matter the mechanism. Heparin, Coumadin, same place. Clopidogrel is Plavix. That's a very common drug. However, what's interesting about that is it's one that's not in the ICD-10 drug table. So this may require you to take a little bit of this presentation out into the world so that you know how to look up the mechanism of these so-called blood thinners and figure out whether they are anticoagulants, antithrombotics. Now, antiplatelet is another term for antithrombotic, and aspirin is one of those. But interestingly, aspirin has its own code set distant from T45, which TPA thrombolytics, sorry, right next to the antithrombotic and anticoagulants too. So even if the ill effect is, and I would welcome a coding clinic or a new rule on this, but if it's an aspirin overdose that causes bleeding, we still code it into the aspirin family right here. So let's focus on TPA adverse effects, because as I said, they cause bleeding. Administering TPA is not without its risk of complications. It can save a life, but it can cause problems too, since it dissolves all those clots throughout the body and it can release blood where it shouldn't be. So there's important considerations to administering it as well as for coding it. So for example, what happens if an ischemic thrombotic stroke is treated with TPA and then develops a so-called hemorrhagic conversion, like the subarachnoid hemorrhage that you see right here? I think the original infarction would have been this dark area here, but it's just kind of obliterated by the blood that's coming from it and entering the ventricles. Here and here is what that blood is there. So this patient had TPA. Is that an adverse effect of TPA? Is it poisoning? It's probably not a poisoning. Clinicians are exquisitely careful about the dosages of this stuff because of the ill effects and because it's expensive. So you'll rarely see a poisoning. It'd be a big accident if it was. But adverse effect wise, it's really quite possible that could be the case. How do we know? Well, sometimes thrombotic CVAs just convert by themselves all the time. Patients that don't have TPA are the proof of that. So whether it's caused by the TPA depends on the timing and most crucially on the provider's documentation. So, but I will tell you one interesting thing to help you think about this in a certain way is that the half-life of TPA is only 5 minutes. So it clears out of the system very rapidly, and it's usually not the fault of the TPA, but as we know, as coders, we cannot make that assumption or determination. I mean, if I was coding a real chart and it converted 3 days after, I would feel more comfortable, but not totally comfortable saying it was not an adverse effect. So ultimately, my advice is you need to query for a connection or not, whether it's an adverse effect of the TPA or not. But you can have a sense for what you're likely to get the result or the response on the query of based on the time span. There are a couple of coding clinics on that relationship and the need to query. If you just were to search for TPA, you will find those. But let's get back to the clot formation. So we covered the coagulation cascade. Let's look at platelets and disorders and coding of those. So the platelets are actual cells without nuclei that both participate in the formation of the clot and then they stimulate particular steps in the coagulation cascade, as I mentioned. The normal count is 150 to 450,000 per microliter, which is about 1 platelet per 15 red blood cells. Here you can see the platelets are these little irregular that are stained differently. I mean, they're not blue in real life, and red blood cells are real and red in real life, but not well shown here because they're stained. But plus or minus, that's not an actual metric. That's just for entertainment for you here. And they're much smaller than the red blood cells, as you can see. Now, thrombocytopenia is the condition where there are too few platelets, and that can be caused by a number of underlying causes and diseases, including a decreased production from things like vitamin B deficiency, leukemia, certain medications, and hereditary disorders too, just like the bleeding disorders or the hemophilias, although it's not thrombocytopenia is technically a hemophilia. Or it can be increased consumption due to various infections, immune thrombocytopenia purpura or ITP, disseminated intravascular coagulation or DIC. Those have to do with using up the platelets too quickly. There are a number of specific codes under D69 to describe these, and often you'll have the etiology for that too. Sepsis is a very common one, let's say, or there could be some inflammatory condition, rheumatoid arthritis, Crohn's disease, and any number of inflammatory conditions, acute or chronic, can cause thrombocytopenia. So don't forget to do that. Code that. Here is just a sampling of the platelet disorders in ICD-10 to do with namely primary and secondary thrombocytopenia, and the unfortunately common thrombocytopenia unspecified that we'll get, and then the qualitative platelet defects where there may be plenty of platelets, but they are not working correctly. I abbreviated this list. There are several other named diseases under here, and even some under here as well too. So that's worth a perusal to note. But the main takeaway here is that there are qualitative functional platelet problems, and there are a number of problems with too few platelets. Thrombocythemia is not that common. That's too many platelets too. Let's dwell on DIC for a moment. Now, this is a condition which causes, ironically, too much clotting in certain places, namely the capillaries, where there aren't any leaks. This is the main problem. And therefore, it depletes the platelets and allows excessive bleeding in other places too. GI bleed and brain are two that come to mind too. Certain conditions such as sepsis, surgery, major trauma, cancer, burns, snake bites. Complications of pregnancies, unfortunately, can cause clotting in the capillaries in the small vessels, which is weirdly to me usually fairly benign, but it uses up the platelets and the clotting factors. So again, you get hemorrhage elsewhere. It's not a good situation with trauma, well, with any of them really, but trauma and pregnancy, particularly ill outcomes from DIC. So DIC is an MCC, and rightly so, because it portends usually a pretty bad outcome. It can be treated with platelet infusions and fresh frozen plasma to replenish what's been used up. But if the root source is still there, causing that overconsumption of clotting factors, it's hard to catch up. So DIC is a pretty serious condition. And then to code this, of course, we've got the initiating condition, we'll just say sepsis, with the DIC, D65, and then the hemorrhagic conditions that may result, like a CVA, for example. Another polling question to see who's still with us.
All right, thanks, Ed. So here's the question that Ed would like to know, and I see I have medical terminology, and for those of you who have been with me, you know that I give it my best shot. So which of the following types of CVA would you not want to use thrombolytics to treat? Hemorrhagic, aneurysmal, or thromboembolic?
Good job, Kathy.
You know, I do my best, and I actually go out and go to the dictionary and practice trying to say these, but you know, under the gun, I sometimes get a little panicky.
Well done.
So we've got about a third of the audience is responding to my medical terminology here. So we do want to hear from you. So which of the following types of CVA would you not want to use thrombolytics to treat? And it looks like we're going to have some discussion. So go ahead, just give us your best thought, best guess. Ed's going to do a great job of giving us some explanation and some answers. So what do you think? Which of the following types of CVA would you not want to use thrombolytics to treat? And it looks like we've got the majority of you have answered. Does anybody else want to weigh in? Okay. I'm going to close the poll. Here's your last chance in 3, 2, 1. Okay, Ed, we've got 86, so the majority of the audience is saying it's hemorrhagic, but we do have a few of them at 14% is saying it's aneurysmal.
Okay, once again, great job. So the message here, which I think you all captured, is a hemorrhagic CVA, like a subarachnoid hemorrhage, would only be made worse by thrombolytics. So that would just make the problem worse. So that's a slam dunk answer. I put aneurysmal CVA, although it's not usually called that, but an aneurysm might rupture, and sort of an old school physician might call that a CVA, but you certainly still wouldn't want to use TPA. So those of you who got that, that still counted, right? The wrong answer would have been a thromboembolic CVA. So that's exactly what we use TPA for. So kudos to all of you. Okay, now we'll talk a little bit about the bleeding and where that blood goes and the problems that it causes. So we explore the underlying issues that may lead to the bleeding, what happens when the bleeding occurs. So there's essentially 3 places the blood can go, out of the body, which I would include into the GI tract, because it is a lumen that opens to the outside. So there's essentially an unconfined body cavity. Then we have inside the body cavity, which may be confined to a certain extent, and the importance of that is how much blood can go there. And then we have the actual oxygen carrying problem that may occur from the loss of blood. So we'll start with intracranial hemorrhage. This is one of the most urgent types of bleeding that can occur, not due to the volume of blood that is lost or any anemia typically, but because of the pressure and the irritative effects inside the cranium, which is a very confined space. And the layer in which the bleeding occurs makes a world of difference at how this affects the patient. A non-traumatic intracranial hemorrhages are classified as cerebrovascular diseases in the I60 to I62 range here. And traumatic hemorrhages are found in the intracranial injury hemorrhage in S06, and have the loss of consciousness, of course, as the elements to the coding. Now, starting from the outside layer in, we have an epidural hemorrhage, which is usually traumatic arterial bleeding. It's high pressure, usually rapid onset and localized to one site. This is what you see here in this patient's right frontal area, maybe the anterior cerebral artery or one of the bridging arteries there. This is not the most common spot. Usually the middle meningeal artery underneath the side of the head, the so-called pterion, which is right behind the temple, is the most common site, usually from some external trauma. Fortunately, not usually by falls, because we have a shoulder in the way, but by an external trauma like an assault. But nonetheless, any area could incur this kind of injury from a fall, like the frontal, as you see here. Now, because of the way that the dura is tethered to the inside of the skull, all of the arterial high pressure blood occurs in one area, and it severely compresses that local brain. Since brain is very susceptible to loss of circulation, all this brain right here is not seeing a lot of blood or oxygen. This blood, of course, is not perfusing it at all. It's just pressing on it too. Now, subdural bleeding occurs under the thick dura. It's usually venous. It's usually slow. It can be spontaneous or traumatic. And the blood is still kind of irritating to the tissue. And I mean, enough of it can compress the brain, but there's plenty of people that walk around with subdural hematomas that don't ever notice it. And they don't always necessarily need to be treated. And these can be acute, subacute, chronic, or traumatic. And there's codes for each of those. And it's often terribly difficult to get the documentation to make sense of it. I wish I had some better advice, but just know that you have those choices. Query if you need to. Now, certain brain trauma and hemorrhagic CVAs both, remember, all of these can be hemorrhagic or can be traumatic or not. They bleed into the inner thin arachnoid layer or under the substance of the brain, or into the substance of the brain itself, like intraparenchymal is what you call that. And brain cells, the neurons, they're exquisitely sensitive to pressure, to ischemia, to the irritating effects of the components of the blood. So there's often a loss of brain tissue and loss of function due to this type of hemorrhage, unfortunately. Those are hemorrhagic CVAs as an example. Now, once again, all these may be traumatic or spontaneous, and it's plausible that they could be both. So be vigilant about that and be liberal with querying when you can, but also be ready to accept that the clinician doesn't know either, and that we just have to fall back on whatever the default is. Finally, on the matter of thromboembolic CVAs that convert to hemorrhagic, we do code both of those too. Here's a quick look at those layers between the skull. The dura here is actually comprised of two layers, the periosteal and the meningeal, but they actually are stuck together through most of the cranium, except at these venous sinuses. The sagittal sinus is one, the sigmoid sinus is one. There's rarely any bleeding into that. So epidural is about this, subdural below, subarachnoid in here, intraparenchymal in the substance of the brain there. Another place blood can go it doesn't belong is into the chest. A hemothorax is, in Latin, is simply that, blood in chest, specifically in the potential space between the parietal pleura and the visceral pleura, which is the part that coats the lung. So that's the pleural space. Now, probably the most obvious source of bleeding here is a penetrating wound, like a stab wound or a gunshot. Not all such injuries cause hemothorax and vice versa. So it's important to code both the hemothorax and the actual injury itself. Neither is implicit in the other, okay? If air also gets in there from a penetrating wound, there is a specific code for hemopneumothorax, and that radiologists will be usually pretty religious about documenting as such. Here is a hemothorax here, where the white substance, blood full of minerals, just like the heart, just like the liver, obliterates the space here, and the lung is actually kind of floating on top of it. This looks like about a 60% hemothorax, whereas there should be air all the way down to the bottom of the lung here at the diaphragm too. Blunt trauma can cause microlacerations to the lung or pleura and cause a hemothorax like this. They can also cause rib fractures, which will then rupture a local costal artery or vein and cause bleeding into the hemothorax as well. So the problem with the hemothorax is twofold. First, the blood compresses the lung, as you see here, and that reduces pulmonary function. And most healthy people can tolerate that part, but if a person's got COPD, maybe they can't, or maybe they're in shock as well, and every little bit helps or hurts, as the case may be with the hemothorax. Secondly, the hemothorax can lead to significant blood loss. Each half of the thorax can hold about 1.5 liters of blood. That's about 25% of your circulating blood. So that will contribute to anemia. And that's a double hit to a patient who's been injured like this too. There are also cases of vascular malformations and sometimes spontaneous, just like pneumothoraces. causing this condition. Cancer can cause a pleural effusion, bleeding, or both too. So it's not something you see every day, but the causes of it are multiple. So now you've got a little better idea how to code those. Hemopericardium occurs when there is blood in the pericardial sac. Depiction is a little cartoonish, forgive me for that. Sometimes you can actually see a level on a X-ray or a CT, but it's not usually quite as clear there. The problem with bleeding inside the pericardial sac is constriction of the heart, particularly its ability to relax. That's diastole. So this can initiate diastolic heart failure with as little as 200 milliliters of blood. And so once again, when hemopericardium occurs, it's not implicit to any other condition. So you would code the hemopericardium and the trauma that caused it if known. And then also consequently, if it's causing cardiac tamponade, that's the squeezing effect on the heart. And then also additionally, any diastolic heart failure or other actual manifestations on the heart muscle itself. And the causes of hemopericardium are over anticoagulation, trauma, both penetrating and blunt, like a steering wheel to the chest on a front end collision can cause hemopericardium. And ironically, also pericardiocentesis, which is also the treatment for hemopericardium on an emergent basis too. So if a patient had pericardiocentesis for one condition and it caused bleeding and they end up with a hemopericardium iatrogenically, the initial treatment for that would be to do it again and then get the patient open and address the bleeding. Now this also can occur with an MI, and there is a specific MI complication code for this. There's that nice little family, some of which are CCs and MCCs, of MI complications. So if you have a hemopericardium, in particular with an MI, go to your combination code. Now, once in a while, it's spontaneous or secondary to some other cause, in which case I31.2 is that not elsewhere classified hemopericardium code. Hemoperitoneum is an interesting condition, which is potentially one of the worst of these for a reason I'll explain. The abdominal cavity is highly distensible and may hold greater than 5 liters of blood, which is more than the entire circulating blood volume for an average-sized individual. Therefore, a large scale or rapid blood loss into the abdomen will reliably induce hemorrhagic shock if untreated. If it's fast enough and untreated, it could rapidly lead to death, even though the intra-abdominal organs themselves are actually pretty tolerant of having all that blood there in the short term. The intestines just sort of constrict and move out of the way. The kidneys are in the retroperitoneum and pretty well protected. One of the causes of hemoperitoneuria would be an abdominal aortic aneurysm, which you see here, this nice straight and tubular thoracic coming into abdominal aorta, becoming irregular and dilated across here, right down to the bifurcation into the iliac arteries. That's a AAA, one of the more common causes of hemoperitoneuria, and absolutely a surgical emergency too. There aren't many ways to treat this outside of surgery too. So hemoperitoneuria is K66.1. When it occurs as well, do not consider it implicit in any of the other conditions, which you would also code as the cause of the hemoperitoneuria. One more polling question, Kathy.
Okay, here we go. A stab wound in the axilla would most likely result in which of these conditions? A hemothorax, hemomediastinum, or hemopericardium? A stab wound in the axilla would most likely result in which of these conditions? I think you guys are thinking. I'm waiting. There we go. Now I'm starting to slowly get some responses. This must be a tough one, Ed. The responses are coming in a little slower, but they're starting to trickle in.
It's as much of an anatomy question as anything. If that helps.
Mm-hmm. Well, and everybody's kind of thinking along the same lines. So boom, we've all of a sudden we've got 3/4 of the audience. Okay. So I'm going to go ahead and close it in 3, 2, 1. And Ed, 100% of them say it's the hemothorax.
Okay, great, you guys. Well, as I said, this is mostly, if I had said just a chest stab, any of these could apply, but I said axilla. So the only thing that's really over in the axilla is lung, so, and pleura, so hemothorax counts. Now, you can definitely have a hemomediastinum or hemopericardium from a central chest stab wound, but that obviates the question. All of you nailed it, so great. Now let's flip to the uncontained, as I say, outside the body hemorrhage, including GI bleeding and external bleeding, since the blood ends up outside anyway and the GI tract is essentially unconfined. So blood can be lost at any rate, nearly instantaneous, like a carotid artery laceration or the AAA rupture, on down to very chronic blood loss, which can result in anemia. Mostly is the ill effect from there. An average human body can compensate for about a 40% acute blood loss before the pressure starts to drop and shock becomes an issue. Conversely, in the chronic blood loss arena, most people can lose about 35 milliliters of blood per day. So it's about 1.2 ounces before they're unable to keep up with red blood cell production. But that's extremely variable. Don't use that in any official factor of capacity, just kind of trivia. So about a shot glass, I guess, of blood per day. This image here shows bleeding from a gastric cancer. This is all, it almost doesn't take a doctor to know this very abnormal looking tissue. Bleeding pretty briskly, that I would wager is more than 1.2 ounces of blood per day. And that's probably what brought the patient in, is some anemia too. The inconsequence of these is anemia, whether acute or chronic or both. So let's look at some of the coding implications of GI bleeding and anemia. So GI bleeding is a problem that's often disappointingly vague for clinicians to diagnose and for us coders to code, because it's just hard to nail down a lot of the time, even with studies. So we're often presented with the general diagnosis of GI bleed and hematochezia, melena, rectal bleed. Those you just kind of have to code for face value. I don't have any really secrets to those. But let's look at some of the conditions we can code a site. Let's say with an endoscopy, the site is identified. Happily, these are some examples of the cases where there is a combination code of, if there's a varix, esophageal varix, at least with bleeding, there's a combination code for it. An ulcer of the esophagus, similarly, there is. So what these have in common is, thanks to the with rule and the OCG added lately, relatively, we're able to assume the causality of that GI bleeding with the condition. So when you have a GI bleed and you have one of these conditions, we could use the combination code for that, which I'll show a few. Now, there are GI bleeding types that don't have the combination codes. Interestingly, for example, gastric varices. So we have one for esophageal varices, but not for gastric. So we would have to code gastric varices and GI bleeding accordingly. Now, because what usually gets the attention for these conditions is the anemia, you would need to code that first. It's usually chronic, but don't assume that. Here, I just took a little snippet of ICD-10 of, let's take diverticulosis, the small intestine, not the common kind, but it does exist, with or without bleeding in the combination there too. So if a patient were to have a small intestinal endoscopy and a diverticulosis was noted, plus even if it wasn't bleeding then and they also had bleeding, this would be code you would use for that. Traumatic bleeding wise, so in all cases of traumatic bleeding, there will be some open wound that we can code, and there's too many locations on the body for me to put examples in, but they're all in the injury codes. And then of course we want to code the anemia that resulted, usually would be acute in this case. Now, what I'd like you to consider is, oftentimes if it's significant enough to give acute blood loss anemia from a traumatic site, there's often a specific vessel that will be implicated. So it's worth looking for that specificity, and occasionally even worth querying for, partly because we're all diligent and specific as we can, but also it will oftentimes give you a different DRG. Like, look at this upper arm laceration too. If we were just to code that as the principal diagnosis, let's just pretend that's the only diagnosis, DRG of 605 with a weight of 0.8757 results. And if it's right brachial artery, different body system, different DRG, 914, the weight is 0.8617. It's very close, but we'd like to get it right, right? Intraoperative bleeding and postoperative bleeding deservedly gets a lot of attention by clinicians and coding alike. So while the usual amount of blood loss during surgery that causes anemia, noticeable anemia, is about 1 liter, but this again is highly variable, so we can make no assumptions about what's abnormal and whether it was actually the surgery and the blood loss that was the cause of the anemia or not. So don't jump to conclusions. We are prohibited as facilities from establishing any criteria on this, as tempting as it is. There's a coding clinic that establishes that. It's really up to these fellows to establish and document that it's a blood loss anemia from that surgery. Now, also, furthermore, blood loss anemia that results from surgery, even so stated, is not by default a surgical complication unless it is said to be so, too. It may be fully expected blood loss anemia, but not a complication. So we fall back on our official coding guideline that it's got to be, and I abridged this greatly, but it must be an indication that the documentation that the condition is a complication of that surgery, and as always, query if necessary. Now about that blood loss anemia too. So from excessive blood loss, acute or chronic, often comes the anemia, and these are 2 basic blood loss anemia codes. Chronic blood loss anemia is typically more a matter of depletion of the red blood cells and the iron that is needed to produce them, whereas acute, as you can imagine, is just the stuff comes out, oxygen carrying capacity is lowered. Now, both of these codes, D62 and D500, have excludes notes against each other, but you will commonly see acute on chronic blood loss anemia documented. There is fortunately a coding clinic on that says, I think logically and happily, we code only the acute blood loss anemia. The metrics of red blood cells are hematocrit, which is the percentage volume of the blood that is red blood cells, and hemoglobin, which is the weight by volume, grams per deciliter, of the hemoglobin component of them. They both have their own significance, and there are many other red blood cell indices to help tell if it's a production problem or loss problem and so forth too. But these are the ones I kind of focus on. Hemorrhagic shock occurs, as I mentioned, we can usually use about 1 liter before we start to suffer some ill effects, and maybe 2 liters or 40% before it starts to get into shock territory. So, the blood could be full of hemoglobin, plenty of oxygen bound to that hemoglobin. If there's just not enough pressure in the pipes, it's just not going to get around. And the brain and the kidneys are particularly susceptible to that, but really everything else. Though the problem here is the low blood volume, this is technically not hypovolemic shock. That's for when a patient is profoundly dehydrated throughout. And so the blood volume is consequently affected, but when there's lost blood, it's classified to other shock, which is, I think, very disappointing, R57.8. Now, there is traumatic hemorrhagic shock, which is usually the case. I mean, you could have hemorrhagic GI bleed shock, which would classify to this, but if it's traumatic hemorrhagic shock and so documented, it takes a completely different turn to T79.4 too. So it just kind of depends on how it's documented and the cause. And then we have intraoperative and postoperative hemorrhagic shock as well. So lots of flavors of that. Very bad thing to have. So I hope that was as fun for you as it was for me. Don't forget to give us some good feedback. I would really appreciate that. And I'll stay tuned, or stay well, and keep your blood in your body. And we'll see you next time. And back to you, Kathy.
Oh, thank you so much, Ed, for a wonderful presentation. And like Ed mentioned, we do want to hear from you. So the survey will pop up as soon as you close out of here. So let us know what you thought about today's presentation. Let us know what additional topics you would like. And please join us next month. Go to our website, and our topic next month will be CPT coding for cardiac cath. So we look forward to hearing from you. Fill out the survey. The recording will be available by late tomorrow, and then follow us on YouTube, and we will do the follow-up questions through our YouTube channel. So again, great presentation, Ed, and everybody go and have a great rest of your day. Thank you. Bye-bye.